Welcome to Quality Time, a Houston Methodist leading medicine podcast. I'm your host, Dr. Schaal, a clinician scientist and a retina specialist, and I serve as the Chief Physician Executive of Houston Methodist, located in the world-renowned Texas Medical Center. I passionately believe that quality is the heart of healthcare, and a commitment to quality is essential for every healthcare system. Join us each month as we discuss the latest advancement in quality in healthcare with clinicians, researchers, physicians, industry experts, and thought leaders who are as passionate as I am. I am delighted to speak today with Dr. Faisal Masud. Dr. Masud is the Mary A. and M. Samuel Daffin Sr. Centennial Chair in Anesthesia and Critical Care and the Medical Director of Center for Critical Care at Houston Methodist. He oversees our 8 hospital intensive care units, the virtual ICU, and the Critical Care Recovery Clinic. He is also Professor of Clinical Anesthesiology at Weill, Cornell, Texas A&M, UT Houston, and the Houston Methodist Academic Institute. Welcome, Dr. Masud.
Thank you, Dr. Schaal, for having me. It's my pleasure.
Dr. Masud, tell us a little bit about yourself.
It's a long journey. I'm originally from Pakistan. I came to this country 35 years ago. I actually wanted to become a surgeon. I was fascinated. And I was a surgical intern at Hopkins, and then I realized that was not my true calling. Medicine, general practice seemed to be a little bit slow paced for me. I thought anesthesia would be the right mix. So I think I'm very fortunate. I did that, and then the journey continued. I did my cardiac anesthesia at Cleveland Clinic. And then because I had nothing else to do, I said, okay, I'll do an MRI fellowship. So I did critical care at Duke. And then I came to Houston Methodist almost now 27 years ago.
Wow, and you lead the Center for Critical Care here at Houston Methodist. Tell us a little bit about that.
Well, the center was created not too many years ago. And really, there are very few Center for Critical Care for academic institutions like us. They are typically critical care, are very segmented, territorial, departmental focus. So this is really a creation of getting all the intensive care unit across the Houston Methodist Hospital system. And there are about 350 ICU beds. And if I include intermediate care units, we're crossing 400 easily. We had to figure out how they will work together, how they will through the journey together. And that led to me starting this Center for Critical Care with support and encouragement from Dr. Boom and Roberta Schwartz. And here we are.
And I know that your rating for quality and safety across all ICUs at the Houston Methodist system is extremely high. Tell us what it is and how do you achieve it?
So our institutional goal, quality is benchmark and foundation for everything that we do. And I think I took that from Dr. Boom's, the quality is the foundation. You do quality focus and all things will follow up. With that being said, all the campuses of Houston Methodist are accountable to Vizient, which is really an organization which benchmarks all hospitals in the country. So I'm very honored to say that the teams that I'm very honored and pleasure to work with deliver world-class care. Our Texas Medical Center, the HMH, is second in the nation in the lowest mortality. The rest of the campus really had the top 6 slots in lowest mortality. And that speaks about the centeredness and everybody working together to deliver world-class quality.
So you're saying that, even though you're in the ICU, which means that you have if you're a patient, you have a very critical condition, right? Very serious disease. the mortality here at Houston Methodist is very low, even though the disease is so serious. Explain a little bit more.
So, what it means, and I'm glad you asked me this question, because what happens sometimes is that we as doctors and leaders get tied up in percentages, scores. I want to make it simplified. And I'm so glad you asked me this question. The chance of anybody coming to our ICU compared to any other hospital system in the country and getting alive is twice as much. That means more than 2 times patient will go out alive if they came to any of the intensive care unit of Houston Methodist compared to any other hospital in the country.
Wow,
And
that's
that
impressive.
is what it means,
Yeah. That's impressive. It's really saving lives. But how do you achieve that? What do you do to make that happen?
I think this will need quite a few days and talks.
Really, what kind of tips? Let's say listening, there are physicians, probably anesthesiologists that are listening to us today, and they may be in other parts of the country. And so they're thinking, okay, well, what can we do to keep our patients more alive and get really out of the ICU? What are the things we need to pay attention to?
I think the first thing is you have to, I personally believe, and my team also very strongly focus on that, is quality is personal to us. And what do I mean by that? It means that, whenever patients, if I'm a patient or any other patient comes to our hospital, what do they expect from us? Do they expect average care? Do they say, you know what, I'm going to bring my mom and do whatever you want to do and just to provide the basic care? What they really want is world-class care every single time. And that's the driving focus, that they're trusting us with the most precious commodity. That is their loved one or themselves. So we have to deliver that. With that mindset that we're going to treat patients and the family, patients and ourselves as like our family, critical care is a team sport. Physicians, nurses, respiratory therapists, pharmacists, physical therapists, chaplain, we all have to work together. And bringing everybody on the same table, giving equal voice to everybody, really following up and keep on constantly learning and evolving, sharing results, respecting everybody's opinion. That, I think, is the fundamental thing which is driving the excellence of care across the system. And the fact is, I brought my family in the ICUs. My colleagues have done that because we know where we're going to get the best care in the world is in our ICUs ourselves.
Yeah, that's amazing to hear. And how do you spread this care, high quality of care outside the Texas Medical Center into regional hospitals all over Houston? How do you do that?
So for a regional hospital in our campuses, Houston is really the most diverse city in the country. And with our 8 campus locations and soon 9 and 10, we really are in every part of the greater Houston. And we really represent pretty much 80% of the U.S. healthcare outside of rural healthcare. And one of the key things I tell you, which I didn't recognize as much earlier on, is how important it is to share and continuously share and repeatedly share, because every 6 months, the workforce keeps on adding up and evolving. Just because we shared one process, one thing in January, don't assume that it's going to happen and people recall in October. So we keep on repeating, we keep on sharing. And the beauty of us working together in a center is that every campus has a voice in developing protocol processes. And what is happening in, for example, our Sugar Land campus, if they're doing a fantastic job and improving something, we learn from it and immediately share all across. I think the power of many drives this thing.
So you talked about developing processes of care or pathways of care. How do you do that? Does it come from other institutions as well? How do you develop these new pathways of care?
The new pathways of care really has to come from the frontline team. What we very strongly believe that in every protocol right now, or even recently since the center was created, no protocol is applied in any intensive care unit unless every ICU in the system has a chance to weigh into that. That means that a nurse who works in one campus can be very comfortable working another campus because they know what to do. And I think it is not an easy process. It's a journey. But I think we are at that stage that people feel comfortable that they can help drive the process. It's not from downtown to the periphery. We are in this together. The philosophy is any patient coming to Houston Methodist ICU will get the same world-class quality of care. The complexity may be different, but the quality should be exactly the same. So I think that is one of the most important things. Another thing what we realized was some of the best protocols exist online and in fantastic manuals, and you can Google anything right now.
Wow.
But that doesn't mean it is being implemented. So it's not only about the processes, but how it is being implemented. How are we measuring it? And can we take back and learn from it? Because developing the process is only the beginning step. Make sure that it's getting done by measuring it and being persistent. I think that is some of the, I would say, the secret sauce or thing which drives our excellence.
So tell me, you had obviously a long career in critical care and in anesthesia in general. What have you seen that changed that field over the years that you were part of that field, since the time that you were a resident?
So a lot, I would say there are some fundamental things that have changed. First of all, when I was a resident, accepting that the complication is normal. An infection is part of the game. Harm is that happens. I think that mindset I don't see that. Okay, harm is not acceptable. Complications are not acceptable. It's not that they are not happening, but they're not acceptable. Infections are not okay to have. I think that fundamental shift is changed. And there is no other place in medicine which is as complex as a critical care unit. Operating rooms are very complex, but they're very short duration. Critical care is a whole 24/7. It's the most resource intense and the most vulnerable patient come to us. So I think that is involved. I think the recognition that critical care can make or break institution has evolved. I think one of the silver lining of COVID was that people got to know what critical care is, what ventilator are. And I'll tell you a small story that during the height of COVID, one of my ex-fellows called me. He was very excited. He was really doing our care. He said, "You know what, Dr. Masud? My mom finally knows what I do for a living." Because it's hard to explain what critical care is. So I think that is the fundamental shift of looking at quality. And the last thing, second last thing I will say is teamwork. I think there's no other place where teamwork has shine and we are all equal. And the last thing is how we're using technologies like our virtual ICU, like our prediction modeling, like our big data mining. I think those are some of the 4 or 5 fundamental shifts I've seen in the last 25 plus years.
So let's piggyback on the last comment that you make regarding technology. I know we are kind of leading the country here at Houston Methodist in terms of virtual ICU and our ability to predict what is going to come. Tell us a little bit about it.
So virtual ICU or electronic ICU or a tele-ICU are all interchangeable terms. And what really it means that you use all the information from the bedside. You have a command center in which a team of specialists, specialized nurses, virtual physicians are actively monitoring those patients.
What information?
All the data. So intensive care unit is where all the patients have they're being monitored. For example, they're continuously being monitored with your blood pressure, your oxygen level, your heart rate. And if you have more complex monitoring being on the ventilator, that is being, or your added machine or medications, all of this thing previously used to be information inside the room.
On the monitors.
On the monitors. And unless you're in the room, you don't know what else is happening to the patient. Plus, we as humans have a snapshot. We are not looking at the trends for the last 12 hours or 14 hours or something like that. We are only we have snapshots. What a virtual ICU is doing, first of all of this information which is in the room is getting displayed into our virtual ICU command center. We have developed algorithms which are highlighting which patients are deteriorating and how many of them are deteriorating. For example, if only your oxygen level is going down, that can be one alarm. But if your oxygen level is going down, your heart rate is going up, your blood pressure is going down, it changes the whole alarm and the complexity, and it starts flashing in a virtual ICU. Compared to if I go to a room, I may not comprehend all of this stuff. So those algorithms that we develop are allowing becoming early alerts, and our nurses and our physicians are interacting with the bedside team. So virtual ICU does not mean that we're taking away the bedside team. Virtual ICU is that we're complementing and enhancing the bedside team with much more predictive algorithms and another set of eyes and layers. There's no better way of performing care. And let me tell you right now, in this country, within the next 5 years, if you are any hospital of any substance, you will have some form of virtual ICU or a EICU or tele-ICU in your system. If you're not there, you're really behind the curve.
Wow. And this really proved itself during COVID as well.
Not only it proved through COVID, let me tell you when COVID, we had to escalate to provide care to almost 500 to 600 beds. I didn't have that many nurses. I didn't have that many doctors. I didn't have that. How do we escalate that? And we had patients waiting in the emergency room. So if we did not have our virtual ICU, we could not have delivered the care. And if you can see the published data, Houston Methodist had some of the lowest number of people really getting harmed with COVID or even having dying by COVID. And whereas we had the huge large numbers with that. Not only that, we had to do what we call as a whole change management about delivering care. What that means is people have to rethink how we're going to provide care as a team, as using technology as a partner. And with that, we can now, with our virtual ICU, we can send a text to any specialist, whether you're a cardiac surgeon or gastroenterologist, anywhere, no matter what phone do you have, you can click on it and you can camera in just like you were physically there. Can you get that anywhere else? No.
So you can camera into the room.
Absolutely. Anywhere in the country, or perhaps you've not gone outside the country yet, but anywhere in the country, you can click on that and you can really zoom in with our cameras and help be there as you were physically there.
Wow. And this is in every bed, ICU bed?
Every ICU bed.
All over our system?
All of our system.
That's super impressive. Tell me more about the team. You mentioned team and teamwork. Who is on the team? Who is part of the team?
So team is anybody who's involved in the care of the patient. And that means, not only physician, nurses, respiratory therapists, physical, ethics, they're a whole multiple layer team, the consultants. But you know what? We also very strongly believe that the patient's family is part of the team. Because please never underestimate the power of families. They are there. They can provide encouragement. They can provide insight. So we look at team, and then if you are working in the ICU part of the team, you may or may not be directly involved in the care of the team, but you are part of the team in some form or fashion if you're there wise. Even if you're cleaning the room, you have such an important role, because if the room does not get cleaned properly, then you're putting this patient at infection. So anybody who's working in the ICU is a team member. So we have to always recognize the value and opinion and feedback coming from the team. And that is what I call is really less hierarchical compared to other places in ICU. It's really collaborative in a team. But the burden is still to the leader to make sure that every member of the team knows their value.
So who is the leader of that team?
The leader of the team typically is a physician, okay? But the nursing director are, I would say, co-leaders. because they are overseeing in so many ways, right? I think they drive the focus. And, and then my job comes into place, not only when I'm working, but to have every nursing director, every medical director be really know what are we aiming for, what we're going to work together, and how we're going to hold ourselves accountable, and how we're going to hold our team members empowered and accountable. One of my favorite thing, which I tell people is, whether you focus on quality and a thing is, make it easy to do the right thing and hard to do the wrong.
Yes.
Okay?
Wonderful.
If you make it easy to do the right thing, people will automatically do it. And it should be more complicated to cause harm. So human nature is why they go with the path of least resistance. And our job as leaders is that the path is going towards excellence in care. Right? So that's it. Make it easy to do the right thing and difficult to do the harm.
Wonderful. You mentioned the chaplains, and we at Houston Methodist are a spiritual healthcare system. Talk to me a little bit about that. What's their role? How do you work together?
So I feel very blessed, and I'm working with a faith-based hospital. And the beauty is, it's all faith. And if you don't have faith, still, we have faith in you. So with our chaplain services, and the beauty is they represent all denominations and faith, traditions. They provide a lot of support, not only to the patients and their families, but to the healthcare team. One of the biggest burnout and mental and physical traumatic is go through the critical care team wise. And they're one of the biggest burnout, especially in COVID. They are there in our multidisciplinary rounds. They provide, become an advocate for patients and their families. They talk to the family. They hold their hand. They pray with them. Please never underestimate the power of faith and belief in your healing and for the team calmness wise. So there are some things which you do not on the faith, but our music therapy also.
Okay,
we have music
more.
therapists in our ICU. They actually round with us most of the time. They provide a dedicated music. It's not about putting iPhones or headphones. They talk to the families, especially if the patient can communicate. They create music, and they play music for the patient family. And we have seen
live
that.
Music?
Oh, live music.
Wow.
And can you imagine you walk into ICU, there is, a harmonica playing or a guitar playing or violin playing. What a beautiful environment.
And I can see that
yes.
here.
And not only that, but we have started that in our lung transplant patient because a lot of anxiety. We realized that you end up using less medication, less anti-anxiety. We have got multiple studies happening right now and to see if we can reduce less sedation and get them off the ventilator, and less depression, delirium if we do a lot of music therapy. So we're very fortunate that we have this thing, and it is a blessing not only for patients and their family, but for the healthcare team. I'm telling you, when that violin is being played in the ICU, that's just a serene moment.
Can you tell us what you've done here at Houston Methodist in terms of preventing infections?
I think this is very fundamental. And one of the, for most of your audience, one of the things which they may not recognize is one of the disease which causes a lot of harm to patients and their families and a lot of deaths, not only in this country, but all across, is sepsis. Now, you can ask me, what is sepsis?
What is sepsis?
Yeah, all right. That's a very fair question. Sepsis is that, that when any one of us gets an infection, whether we get infection in our lungs, in our skin, anywhere else, most of the time, body is able to handle that with or without extra support. But sepsis is when we get an infection and body's response to that is overwhelming.
Mm-hmm.
That leads to different organs of the body getting harmed. And when that stage happens, that's where they go into sepsis. Sepsis impacts 1.7 million Americans, and approximately 350,000 die every year. That's huge. Overall, on the worldwide, is one of the top cause misery and death all over the country. So when you brought about infection, if you get an infection at home, at hospitals or ICU, and if we don't recognize it early, we don't treat it, and we don't prevent it, a lot of harms come to place. So we started our journey to treat, identify, and do a lot of work in sepsis almost, I would say, 18 years ago in Houston Methodist. I'm so proud of the teams and a generation of people who've gone through with this thing that, and initially our death rate from sepsis, and which is similar to the rest of the country, was about 35%. What that means is that every third person who got septic died. With all the work that been generation from technology, from processes, from quality driven one, we're able to now 6 to 7%.
Wow.
Almost 80% reduction. We have saved, thousands of lives, millions of dollars. And the work that we've done, we did not limit to Houston Methodist. We got grant from CMS. We taught a lot of part of the country. Our work, we shared it not only in US, but different parts of the world, because really it's changing the whole healthcare delivery. And all the work that we've done, which has been acknowledged internationally by an organization which is known as Global Sepsis Alliance, which is part of 100 countries and organization. They chose our work at Houston Methodist to get the first hospital system to ever get an award for all over sepsis. Like, for example, the award they gave was to NHSN in United Kingdom, CDC, Africa Alliance, but they chose Houston Methodist because in the acknowledgement, they said that the work that you're doing in fundamentally different changing part of the guidelines and sharing with the rest of the world is paramount. And I tell you, this is what I talk about is continuous quality improvement.
Amazing. Tell me a little bit about the phase after a patient is discharged. You told me that it's 2 times likely to survive whatever brought them to the ICU. What happens after?
It's a very important question. And that a question which has not been asked a lot. About a couple of million patients go through ICUs across this country. A vast majority go out alive, but some of them don't make it, as we all know. But what we realize, and I have to give to some of my colleagues across the country, very few, a couple of them on hand, who also started to think it's just not good enough to get people alive. Human beings, even myself, I want to have a quality of life. I want to have a meaningful life. I just don't want to be alive. So for us, it became a very personal thing that it's just not good enough to get people alive. And what the data has shown, that patients who go to the ICU, who spend a couple of days in the ICU, who are on a ventilator, who are very sick, and we use the term shock, and different kind of shock. So you don't have to worry about what kind of shock, but if you go through a shock, or if you're in different ICU, those patients are not the same when they get home. Families don't know what to do. And those patients have psychological issues, extreme weakness, extreme nutrition issues. That means they're not eating properly, they're not sleeping. They're described by literature, very well studied, that patients and their family go through PTSD. Mm-hmm. So we created a critical care recovery clinic, which is the first in Texas, part of the international organization, which there are only 39 in the world.
Wow.
In which we offer and we start seeing patients while they're in the ICU, in the hospital. We develop a relationship with them. When they go home, we follow them. We have them come to our clinic. The first appointment typically is 2 to 3 hours. We do the nutrition evaluation. We do the psychological evaluation. We look at medication. We look at their breathing. We look at not only patients, but their families. And let me tell you, some of the times we have heard from families that they told our team, you know what, when we asked them, how are you doing? How are you coping? They said, nobody's asked me this question. They're only focused on the patient. That's not bad, but nobody asked me. We feel the families also go through similar trauma, not as much when the loved one is there. And that is, as I mentioned, first in Texas. It just started a couple of months ago.
So in that clinic, you're treating the patient and their families.
Absolutely.
And who are we? We are treating. Is this the same physicians who treated them in the ICU or different team? Who are these people?
It is led by a critical care physician because critical care physicians know really what has happened to the patient. It's not that the primary care doesn't know, but they don't know the complexity they go through. So led by critical care physician. We have also a nurse practitioner part of the team who do the initial evaluation, who do all the assessment, who do a lot of mental score evaluation and everything. And when that is done, if they feel they need a pulmonologist, they'll get them. If they need a psychologist, they'll get them. If they need a neurologist, they'll get them. And then coordinate the care. And not only coordinate the care at patient, the family level, but they get all of the information back to the referring doctors, back to the primary care. So the chain, it remains and the communication remains. So our job is to really identify those issues. And I'm telling you, some of the things which we realize is people have a lot of problem with medication still.
Yes.
They don't know what and why. So we're doing that. They're very weak. And the team is actually not only one visit, but they're constantly interacting virtually and on phones and other ways. And the families are sharing their journey. Now look at that. That is what we call as delivering care to not only during the ICU, but after the ICU. And I'm telling you, we are the first in Texas, part of the international organization, which is Critical Illness and Recovery Organization. I have to give credit to my colleagues in Vanderbilt. They started that, but it is not easy. So that's why there are only few in the country, but I think that's how you
I'm
lead
sure
medicine.
the families appreciate it very much.
They love us.
Yeah, I'm sure. Dr. Masud, I'm listening to you and, kind of you're a fascinating man. And I heard you give some talks about compassion. Tell us a little bit about that. What is compassionate care? We know that compassion is one of our ICare values here at Houston Methodist. What does it mean to you? And why are you driven to give these talks and to educate and inspire the next generation?
You brought a very interesting. This is something which I, start to learn about myself. I read a fantastic book about compassion a few years ago, and I realized I need to change who I am in taking care of patients. I typically ask people, what do you understand by compassion? And typically a lot of people gave me answer, which is more empathy, feeling sad for people. Oh, I feel bad. I feel that they have a hard time. And I realized that there's a very big difference between empathy and compassion. Empathy is the feeling that you feel that something is not right, you do. Compassion is really about action coming from empathy. What can I do to make a difference? What can I do to change things? And I think and actually scientifically people have studied it, empathy stimulates the pain part of the brain. Compassion stimulates the happiness part of the brain.
Interesting.
It's fascinating. It's not about compassion. Is really about recognizing patients and their families, recognizing about yourself, recognizing about the team that you're working with. And really about compassion really is making a difference in that. And one of the most important things I did for myself is that I realized that when I go and talk to patients and examine patients and family, I was talking a lot more. I was telling them, then we're going to do this, we're going to do that, this. I realized I need to listen more.
Interesting.
And I realized that when I listen more, I learn more, they relate to me more. And I also realized after I listened to them a lot, whatever I told them, they accepted and they did it much better than it was previously. I was not listening to them. I was telling them.
Yes.
I realized that about myself. And I'm still working on it. I'm telling myself, I have my heart here to do that. So I think that, but compassion is not only about patient care. We have to be compassionate to ourselves. We have to be compassionate to the people that we work with. We have to be compassionate to our families.
Yes, which is a very big issue, right? With a very busy physician, especially earlier on, you kind of leave your family somewhere and you're in the hospital all the time.
You're absolutely, we forget that just because I entered the hospital, that there's an on and off switch that I'm forgetting everything happening in my personal life. And when I leave the hospital, everything happening in my professional life. That doesn't happen. They're all interrelated. And compassion doesn't mean that compassion only comes in after you develop a world-class quality of care. You have to do the foundation.
Perhaps it's part of quality of care. What do you think?
It is. And you know what?
We don't measure it. I don't know how to measure compassion, but it's part of high quality of care.
People have figured out how to measure compassion and by surrogate markers. They've realized that doctors and nurses who spend a little bit more time and how do they communicate to the patient and the families, the patient satisfaction scores go up, less complications happen, less waste happen. And so there are secondary markers which are showing some of the things that compassion make a difference. And guess the organization that we work is one of the core ICare values, ICARE.
Right.
Okay, what does C stand for?
Compassion.
Compassion.
Exactly.
It's fascinating.
I love that you said, compassion for our patients, compassion for our team members, compassion for our family, and then compassion for ourselves too. Sometimes, as physicians, specifically in critical care, where you see very, very tough cases, you may be hard on yourself. Should I have done this? Should we have done that? Could we have saved that person? And I'm sure that, compassion for ourselves is a critical part there.
It's so important, and you have to it's an exercise you have to keep on doing. Now, people may see that I cannot be emotionally connected to people because I will not be able to make objective decision. That is a mantra I was trained. So it's not about being not able to make good objective decision. It is about recognizing that they are human beings. Mm-hmm. Their feelings, the families have feelings, the healthcare team has feelings. It's about I have feelings. So if I don't acknowledge them, I may come across harsh. I may come across being more harsher to myself or anything. And people actually study that people who are not more open to that, they have more harms and more burnout.
Yes.
And again, it is the foundation, compassion care does not means that if the patient is asking us an unreasonable things or the family is asking unreasonable thing, the compassion doesn't mean that I accept and agree, say yes, yes, yes. Compassionate, listening to them, acknowledging where they're coming from, and then guiding them to help make better decisions. Mm-hmm. That is what I call as compassion care wise. So compassion is not this versus that. It is the and.
Yes. Wonderful. Well, we covered a lot of topic in this short conversation. I really enjoyed your presence here. I would like to end with a question that I ask all my guests in this podcast. What does quality mean to you?
Quality, I think maybe I answered earlier on, but I feel a quality to me is a personal endeavor of all of us. In my heart, I believe that we are in healthcare. It's a calling. It's a fantastic career from every angle. I very strongly believe that all of us, when you come to the hospital's clinic or doctor's office, do what's best for the patient.
Dr. Masud, you're such an inspirational figure here at Houston Methodist. I'm sure in your profession, everywhere else in the country and the world. Thank you so much for being our guest today.
Thank you, Dr. Schaal. It's my pleasure. Thank you.
And thank you for listening. Quality Time is part of Houston Methodist Leading Medicine series of physician-led podcasts. So that you never miss an episode, subscribe to Quality Time. New episodes will download to your podcast device. If you enjoyed our conversation today, please consider rating this episode and sharing it with your colleagues. I appreciate your support. Thank you, and until next time, I am always listening.